Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of colorectal cancer, part 1. Dr. Travis Brown, we've covered many topics on This Medical Life. We've never done a 3-part series. Why does colorectal cancer demand such attention?
This is a very large topic. This is a topic that takes up a great deal of time in healthcare. It is the true multidisciplinary approach to cancer treatment. We have everything going from screening, diagnosis, management, familial pathways in and out of this. It is our large conglomerate of departments. And look, at the outset, it's also thanks to Dr. Tristan Rutland, who has helped pull these episodes together, helping us get guests, because again, this is going everywhere from straight pathology testing, with screening, all the way through to chemotherapy, cancer genetics, radiation oncology. And it is genuinely a difficult area for patients. It can also be an area of anxiety because, my father or my parents had this, will I get it? And so we wanted to go the full gamut.
And isn't it also the case that it is an area of medicine where we have the greatest frustration because we have a wonderful system for screening and not everybody takes it up, and that could be preventing a lot of angst?
This delves into an area of medicine that a lot of people, there's an ick factor. and this is part of where people start to go, this is an episode where we have to say the word poo or feces and dealing with that. Now, when you're dealing with young kids and everything like, toilet training, this is part of the conversation. As soon as you get past toilet training, we don't talk about it. It's not what we talk about in polite society. You don't ask someone at the, theatre, how are you going?
Oh, you just used the restroom on the Bristol chart. What was it?
And so this is a discussion that is critically important. And what we find out is that, yes, there is a screening procedure for this, and people are starting to get a little bit familiar with this, but it's also still something that you sort of, I've got this specimen, or, I have to take a sample. People might find it confronting or yucky or put it away. And this is where we're starting to go, that putting away test can be really valuable. And again, cancer has always been with us. It will continue to be with us. But early detection is the greatest treatment for this condition. And look, as I said, the reason why it's probably far more prevalent now than what it was is because our ancestors died of diseases before you'd get accumulated errors in cells to be able to develop cancer. There is actually evidence of Egyptian mummies who are older than the average, population that lived back then. There's a male who's expected to be around 50 who was found an ancient Egyptian mummy who has evidence of colorectal or rectal cancer that they found on tissue, this invading polypoid lesion that goes into the perirectal tissue. And so this is something that is much rarer, but people are living longer, and we've gotten under control of infectious disease as best as we can at the moment. So when we look at colorectal cancer, it accounts for about 10% of all cancer diagnoses in Australia. So it is actually really prevalent. It's the 4th most common diagnosed cancer in Australia. And even in the last 30 years, if we look at the early 1990s, 5-year survival was around 56%. With the latest statistics of this is 5-year survival for colorectal cancer is around 71%. So even just in the last 3 decades, we are getting better at treating. We're getting better at managing. People are living longer with this diagnosis or getting it treated early. And so we can do better. we can improve, we can detect people earlier. And again, this starts with screening and will end with management in this episode series. So the first place to start is, where are we with screening?
Professor Ken Sikaris is a chemical pathologist and Director of Chemical Pathology at Dorevitch Pathology. Professor Sikaris is a NATA-accredited laboratory assessor, founding fellow of the RCPA Faculty of Science, and a principal examiner in pathology informatics. He is a fellow of the Department of Pathology at the University of Melbourne, and Ken is a regular guest here on This Medical Life podcast. Ken, welcome back.
Thank you, Steve. Great to be back.
Now, Ken, I've got first-hand experience with what I'm about to ask you, but I need to get it from your mouth. What is the National Bowel Cancer Screening Program?
Colorectal cancers, one of the most, I think it's the second most common cancer in Australia after lung cancer. And so, it's natural that we should want to have a screening program to detect bowel cancer. And about 20 years ago, it was proposed that there is a screening test for bowel cancer, which is to look for blood in the stools, in feces, in poo. And because early cancers tend to bleed slightly, very slightly, you wouldn't even notice the blood in the poo. The blood can be red blood or black blood, but this is way below that level. It's sort of just at a chemical level. So that would be the earliest chance that we would have in examining or doing some blood tests or fecal tests to detect colorectal cancer. We used to have blood tests that, there's some markers released from bowel cancers. They were hopeless at detecting early cancer. This was achievable. So the government did a long, review of the literature in the 90s, and they found that, yes, fecal occult blood testing could save lives, and so they set up some pilot programs in the early 2000s, and they were successful, and gradually it's expanded to what it is today. So today, people between the ages of 50 and 74 get around their birthday, around their 50th birthday, let's say, they'll get their first screening test posted out to them. And then every 2 years after that. That's very different to how we started, because it was every 10 years, like you had your 55th birthday and your 65th birthday. And yes, and it started at age 50. So they lowered that to from 55 to 50. And even now, you can start at age 45 if you register for it, but they're not sort of imposing that on the population. If people want to start at 45, then they're welcome to, but the national program, the posted program, starts at age 50.
Talking of the posting program, because obviously I've done a couple of those thus far. There are two things involving doctors where I get a bit squeamish. One is when you've got to go back to the surgery with a urine sample and you kind of hide it in your hands as you pass it over. And the other one is going to the letterbox and putting a parcel in there that contains part of your number twos.
Yeah.
Did that aspect lead to any issues with getting this posted cancer screening program up and running?
Yeah, well, when it was first proposed, we had that image. Like, you mean you're going to get some poo and put it in a plastic bag in the envelope, and and we had to check with Australia Post. And we had a lot of resistance in the first pass. It's like, you can't post poo in the post. You just forget it. And then as we gradually discussed that issue, because it's really just a tiny microscopic sample of poo that you pick up with a special stick and that you poke into the poo. And then that's put into a plastic container. So there's really not any loose poo in an envelope or anything. But the thing it was interesting, the final straw was that we had to convince the Australia Post people that, this was all safe. And and tolerable. And so they introduced a nausea allowance for postmen. And once the unions had approved that this is something that is, in the public interest, and their feelings about the matter are being considered, it was a green light, and off we went.
Now, one of the issues raised in the early days of this testing was there was difficulty distinguishing between human blood and sort of that of animals. So if someone had eaten meat, then that it might test positive. Was this true?
Look, it may have been in rare circumstances, but the test the antibodies that we use to detect the main protein in blood is hemoglobin, the red part of the blood, and that differs between animals. The protein structure of hemoglobin differs in humans from animals, and so they develop the antibodies to only be selective for human hemoglobin. And so it's not true. And gradually over the years they've refined that more and more. I mean, so that's a main issue, that the antibodies are specific for human hemoglobin, so it doesn't really pick up animal poo.
How was the proficiency test for this done then?
The initial stages, there were a couple of laboratories involved, so they wanted to make sure both laboratories were detecting the same low levels at an equal rate. You don't want to over-detect it, because the follow-up test, which we haven't discussed, is colonoscopy, and that's quite expensive. So we don't want any false positive just because the method's reading high. And so we had to develop a program to make sure all laboratories in the program were measuring the same level consistently. And typically the way we do that is we send a sample to both labs and make sure they get the same result. But it's the same sort of issue. You can't have human hemoglobin because it has a certain stability, blood in poo. So we needed to create a stable form of poo which isn't infectious and nauseating and all of that. So we designed, and I'm pretty sure that's what they still do today, we needed something of the consistency. Sorry to be, I hope nobody's eating dinner, but the consistency of poo. So we chose peanut butter, and we mixed some blood in with the peanut butter, and that was the standard. We knew exactly how much blood was in the exact mass of peanut butter, and that was slightly less nauseating.
You've just ruined my favourite breakfast.
Now, how effective has this program been?
Look, it's been very effective. It was expected that it would reduce mortality from colorectal cancer by 10 or 20%, and that's what it's done. It would do more in terms of the national figure if there was more compliance, but people don't. Every screening program has sort of a cap on compliance. I don't know why it is that people don't take on free, testing, preventative testing, but generally, if you get anywhere near 70% compliance with a preventive procedure, you'd be thrilled. The colorectal program tends to be around 40 to 50% compliance. So, but even at the rate that people that are being tested, there's about a 20% reduction in colorectal cancer deaths in the people that participate in the program. And that adds up. Because it's the second most common cancer, that adds up to, tens of thousands of lives that are saved.
Ken, it's staggering, because when we spoke about this a while ago, you said the sad thing is there's a number of these kits just sitting in someone's cupboard at home. They haven't passed it in. Do they then get the next 2 years, or do they get taken off the list if they don't send their kit back?
No, they don't. The registry keeps a watch on everyone. They don't want anyone to slip between the cracks, so they get reminder letters, and they won't drop out of the program. You can go on to the National Cancer Screening Register and opt out if you're really tired, you're never going to participate. And you can actually ask for a test earlier or later if you're going on holidays. So it's a very flexible program, but they really don't lose track of anyone. they're really great that way, and they're making sure that people don't miss out. But that is an issue, the huge issue that, and let's say that figure of, let's say 60 to 70%, there's 30 or 40% who'll never do it, but generally 60 to 70% who would want to do it. So why is it only 40% that actually do it? It's exactly what you said. They forget. They put it in the drawer and they forget. And people have done studies of that. And the people that tend to turn up are the ones that, put it in a place that's visible to remind themselves, or put a post-it note on the fridge, or do something, and probably electronic nowadays, a reminder to make sure they do it. Because I think most people do have the intention of doing it, but they just forget.
Does the testing method make any difference, such as either immunohistochemistry on the actual physical test they're doing?
Yeah, look, that's a really interesting question, because when we started the program, when we were looking at the program in the early 90s, the initial test wasn't this sophisticated human hemoglobin immunoassay. It was a simple test that looked at the presence of heme, iron and heme, in blood, and that was a chemical test called the guaiac test. It was sort of the oxidative ability, the rusting capability of iron in the feces. And the initial studies that showed the saving of lives were all done with the chemical test. And so when we said, in 2000, the standard is immunochemical, it's a far more specific test. It was an act of faith to actually say what was achieved with the chemical test in saving lives will be seen with the immunochemical test, because we know it's a more specific test. So by more specific, I mean that the chemical test, because it relates to iron and heme, which is the same in all animals, does react to diet. So if you eat meat, then heme will appear in your feces. And so, the chemical test will pick up dietary meat, but not only dietary meat, anything that's got that oxidizing capacity in food. So horseradish, and there was sort of different things that you might eat in food. So the preparation for the screening test using the chemical test was to avoid all of this whole stuff in the food. And if you didn't avoid it, you would get a positive, heading off for a colonoscopy. So it was sort of so we thought it would be far more specific to use the immunochemical test. But as it's proven, we're wondering whether it'd be more sensitive as well. But the chemical test is quite sensitive. So at least it's equal. It's what we can say. It's equally sensitive, but far more specific. And there's one thing though with that test, because we've sort of almost forgotten about this chemical test. There's one big difference between the chemical tests in terms of disease diagnosis, and that's with hemoglobin, human hemoglobin, even with animal hemoglobins. When you eat it, the stomach acids and your proteolytic enzymes, the things that completely destroy hemoglobin in the upper bowel. So the only hemoglobin that survives in feces is bleeding from the lower bowel. And that's important clinically, because when you do a fecal occult blood test with immunochemical test for human hemoglobin, it won't pick up bleeding from the stomach. I mean, it's good because it won't pick up bleeding from your gums and teeth as well, because it's denatured by the time it gets to the large bowel. But clinically, that's really important for clinicians to know, because if somebody's got, let's say, an iron deficiency, they're wondering about occult blood loss, and they do the current immunochemical test, they've probably ruled out lower GI bleeding, but they haven't ruled out upper GI bleeding. And I think that there's still a place for that. Unfortunately, people have forgotten about that. And it is a concern of mine that people just have the blind faith that there's no intestinal bleeding. No, there's no lower intestinal bleeding.
You need multiple samples. It started off with 3, but now it's down to 2. Is there any reason you need multiple samples and then it's gone from 3 to 2?
It's sort of logical that the more you do, the more sensitive it would be. These polyps and and tumours tend to bleed intermittently. They don't bleed constantly, they just bleed intermittently. And so in a way, the more opportunities you take to detect that, the more your sensitivity. But there is a false positive rate with the assay. And so the more tests you do, there's a saying in medicine that, there's no such thing as a healthy person, just somebody who hasn't done enough tests yet. And it's true, if you just keep doing fecal occult bloods, one of them will be positive. It might take you 1,000 goes, but one is going to be randomly positive. So there's an interplay between improving sensitivity and worsening specificity as you increase the number. And because the test is so specific and sensitive, with the guaiac test, you may need 3 tests to balance the sensitivity and specificity. But with the immunochemical, it's proven that 2 tests is enough to get a maximal sensitivity without worsening specificity.
This is something I haven't come across before, but what role does this, now let's say ACSQHC colonoscopy atlas variation play in all of this?
The Australian Commission of Safety and Quality in Healthcare are really interested in how healthcare is used across Australia, both safely and equally across the population. And what we know is that deaths from colorectal cancer, just as with every disease, are worse in rural and remote communities. They don't access health services as well as they could. And the part of that's geographical, but part of it's also promotional. And now, so that applies to the FRBT program as well. So, and with the FRBT program, they go to incredible lengths to make sure that everyone in the population has access to the post-it. And just a bit of a detour there, it's pretty hot in outback Australia. And so when you're posting kits and samples back to the lab, they can be harmed by the heat. And so in particular postcodes, they don't send out kits in the months where the average temperature is over 30 degrees because the results are unreliable. So I'm just saying that the program really does try to look up after all Australians and make sure that they're all accessing the program. But then with colonoscopy access is, again, in the affluent suburbs, people are getting colonoscopies far more than you'd expect based on, prevalence of diseases or FOBT screening, and in the remote areas, they're not being accessed. So they know that there's a big discord between the disease prevalence and the preventative measurement, and so they prove that with colonoscopy. And so we need to somehow tighten the relationship between this effort in the colorectal screening program, making sure everybody gets screened, and everyone gets a colonoscopy for that purpose. It may sound simple, but, to try to get specialists out to those communities and have colonoscopy, services equally available across Australia is something that Commonwealth and state governments need to work at, because we know that it's affecting lives. And the Australian Commission have addressed that, and there's been a recent review of the Medicare items for colonoscopy, and they're going to really try to adjust the way that it's billed and accounted for, so that we can have greater confidence that the colorectal screening program is driving its proportion of colonoscopies wherever it is available in Australia.
Mm-hmm. You mentioned it before about the testing going from 50 to 45. You can opt in and register at 45. Is there any likelihood that it's going to? We're hearing a lot about, young people being diagnosed. It's probably anecdotal, but I'm hearing a lot about it, about, 45-year-olds getting, cancer that's quite advanced. Is there any discussion about making the screening age go from 50 to 45?
The younger that you have a cancer, the more likely it is to be familial and genetic. And so it's about 20% of colorectal cancer that belongs to these family cancer syndromes, like familial polyposis coli and so on. And so the younger you are, the more people look for some family history to justify the likelihood that you're going to get a cancer earlier, because, it's very uncommon to have colorectal cancer below the age of 50. But in a way, to prevent colorectal cancer at age 50, you probably do need to screen 5 years early. That's what the idea between the 45. But to screen 10 years earlier means that they must have a different type of colorectal cancer. So at the moment, it's all focused on familial cancers below the age of 45, let's say, and routine screening from 45 and above. But really, the FOBT test is available in Medicare. You don't have to be part of the program. You can go to your GP, and if they and you are concerned about it, you can have the test. It's available through Medicare. Just on that point as well, people have wondered, because a lot of those people who don't return their FOBT kits have seen their GP in the months around that period. And people know that if your GP, if your own GP, particularly, the one that you've been regularly seeing, really promotes you to be involved in the program, you're much more likely to be involved. So we do need greater GP engagement in supporting the program and doing the testing outside the program if they think it's necessary at that time. So I agree with you, Travis, that it should be front of mind. You can't just say, no, I don't need to worry about colorectal cancer. The screening program's looking after it all. No, GPs have got a vital role in supporting the program and testing outside the program whenever they think it's necessary.
What percentage of people who have a positive FOBT will have cancer?
It's a small percentage. It's like 20 to 30%. But that's the same in any screening program. In a way, if you did a screening program and 100% of people had cancer, you'd say, well, we must have missed some. And on the other hand, if you do too many false positives, then it's a very expensive thing in terms of follow-up colonoscopies and the time. So generally in screening programs, around a 30% positive predictive value, so 30% of the positives turn out to be true, is considered the sweet spot. We've only inconvenienced 2 people for every 1 person who might have had their life saved. That's sort of considered a good balance. But, if you're inconveniencing 10 people for the sake of 1 life saved, you're starting to, ask more than what people would be comfortable with.
Are there any false positives and false negatives?
Well, the false negatives can be due to that hot zone problem, but that's covered. The false negatives do happen, like the cancers bleed intermittently. And so, whilst we might have been better doing 10 FOBTs in a row to pick up all cancers, it just creates too many false positives. That positive predictive value just goes out the door. So it will miss cancers because of the intermittent bleeding. Now, and that would be, and that's really the main reason why we've tried to reduce that 10-year window to 5 years and now to 2 years. So that even if we miss it in one screening program, we've got a high chance of picking it up in the second screening test in 2 years' time without it having advanced too far. So it is that is a cause of that's the main cause of false negatives. False positives, there are other diseases that cause bleeding from the gut. Benign polyps. For every cancer that they find benign polyps. Now, they're not really considered false positives because polyps can develop into a cancer, but they weren't actually a cancer. So it's arguable whether you call them false negatives or not because they found something which might have been preventative. But there are some inflammatory bowel diseases like ulcerative colitis and so on that can cause bleeding from the gut. Hemorrhoids and things are hemoglobin that can cause positives. Menstrual blood can sometimes be contaminating, and so that will cause. But that's that's maybe another reason why we don't really want to lower it down to age 30 and 40 in women, because we'll start getting a lot of false positives from that as well. So, but yeah, there's not that many false positives, really.
So, I mean, there was just one point that I wanted to make with regards to actually testing and sort of highlighting it for GPs, is that just because they've had a negative screen doesn't mean 6 months down the path or a year down the path, if someone has symptoms that are symptom indicative of, you know, whether this could be colorectal, that negative test does not necessarily mean that they don't have that. And so it's actually highlighting that they need to sort of then go on down the path, but not to put too much faith in the screening test, because it literally is just a screening test.
Yes.
Ken, is there any advice or any final thoughts that you have for doctors or patients?
Well, patients, it's that issue about when you receive it, most of you will want to have that test, and it's a matter of just bring it front of mind so you complete it. I'd also say to the patients who decide not to have the test, they're free to make that decision for themselves, but they really should consider their family and the community, that dying of metastatic colorectal cancer is not a pleasant thing for your family. So if you're not doing it for yourself, do it for your family. And one of the reasons why the government's supporting this, apart from the care of its taxpayers, is because it's very expensive to look after patients with metastatic cancer. It's well over $100,000 a year once you reach that stage. So I know people won't do it for the sake of the tax department, but really it is a responsible thing to do, not only for yourself but for your family and for the community. For doctors, I think what Travers is saying, please encourage your patients to be involved in the program. We know that there's nothing better than GP, endorsement of the program to improve compliance.
Ken, I can guarantee that every time that kit turns up, I'll think of you and do it.
Oh, no.
And likewise, every time I reach for a jar of peanut butter.
Oh, no.
Professor Ken Sikaris, thank you for being on This Medical Life podcast once again.
My pleasure.
Dr. Milan Bassan is a gastroenterologist and the current Director of Endoscopy at Liverpool Hospital, who obtained a fellowship of the Royal College of Physicians in 2011. He has completed training in advanced therapeutic endoscopy at Westmead Hospital and the Therapeutic Endoscopy Group at St Michael's Hospital in Toronto, Canada. Dr. Bassan is a VMO gastroenterologist at the Liverpool Hospital and a conjoint associate lecturer of the University of New South Wales. Milan is a returning guest on This Medical Life podcast. Milan, welcome back.
Thank you.
From an endoscopy perspective, is there any significant difference between a patient who's been referred for endoscopy who is symptomatic versus a patient referred with a positive bowel screen?
I think the first thing to remember is that the fecal occult blood test is a screening test, and this really should be reserved for individuals without symptoms or with any other indication for endoscopic investigation. And whilst patients with a positive test do need further follow-up, these patients are still at a relatively low risk for cancer. A symptomatic individual, I think, is of more clinical concern, as a colorectal cancer is not usually symptomatic until it's more advanced. And so these patients, if they have cancer, are probably more likely to be advanced, and I'd consider them as more urgent than those with a positive fecal occult blood test, though no other symptoms. Although all of these patients would meet our sort of category A criteria for colonoscopy, so ideally they should be having their procedure done within 30 days. The greatest concern, though, is the patients who have a positive fecal occult blood test and also have symptoms. And these patients often have had trouble for a while but have sort of not been able to get medical care or haven't sought care, and then it's only when they've received this screening kit and then got the positive result that they go and see their GP for the results and then go, oh yeah, by the way, I've also had this change in my bowel habit and bleeding or weight loss. And these are probably the highest risk individuals out of all. And this is one of the strategies during the COVID pandemic when there was a lot of reduction in endoscopy activity, which we used to sort of try and risk stratify patients to go ahead with procedures. And if you had a patient with symptoms and a positive fecal occult blood test, I think our colonoscopy capacity was reduced by something like 80 to 90%. These were the patients we'd prioritise.
When we're looking at patients, what percentage of patients who have a positive bowel screen test will have a positive endoscopy for cancer?
The latest data from the National Bowel Cancer Screening Program, so the data published this year was from 2022. What they found is out of the stool tests they sent out, about 40% actually did it. So the uptake still hasn't been great. But out of those who did it, about 6% had a positive test. And if you had a positive test, about 4% of the people with a positive test actually had a proven or suspected colorectal cancer. So it's not a high proportion. 14% had a proven precancerous polyp and a further 40% had polyps resected, but when they entered the data into their registry, they didn't have the final pathology available to actually confirm what type. But it was a fairly incomplete data set, so there's been lots of issues with reporting just because of the scale of the data. And so there probably are actually a higher percentage of patients who have significant polyps than even what they've recorded, because just on population data, you'd expect at least a quarter of females and probably 35% of males over the age of 50 with no symptoms would have a significant polyp, and then having the positive fecal occult blood test would make it even more likely that they'd have a polyp, and in particularly a more advanced polyp.
What are some of the most common findings in patients then with a positive fecal occult blood test, including maybe cancer, but what other options are there?
So I guess caveat to answering this one's one that I've touched on, that the data around the outcomes is incomplete, and especially when it comes to other benign findings apart from cancer and polyps. And so a lot of what we talk about for this point is really kind of anecdotal based on my experience, and I've sort of asked a few colleagues in our unit as well. I guess the first thing is with a positive fecal occult blood test, these tests are designed to detect blood in the stool at a very, very low level. And this means that they are very unlikely to miss a colorectal cancer, but at the expense of a very large number of false positive tests. So a lot of patients who have positive tests won't have cancer. And as we discussed before, it's only about 4% of the positive tests that are actually due to cancer. Probably half the patients will have a polyp, though it's debatable whether these polyps were actually the cause of the positive fecal occult blood test. But there is really good data to show that if you find these polyps, you remove them at colonoscopy, then in the long term, you're reducing the incidence and mortality of colorectal cancer. And when you look at the long-term benefit of the bowel cancer screening program, it's probably actually going to turn out that finding polyps and removing them, and then the longer-term reduction colon cancer risk is going to be the biggest benefit. When we look at other findings at colonoscopy with a positive fecal occult blood test, probably the most common thing are going to be simple perianal problems such as hemorrhoids or fissures. Sometimes we'll see colonic diverticulosis, though in the over 50 population, it's sort of almost considered an expected finding. So again, debatable whether that will cause a positive FOBT. Sometimes we'll see benign vascular lesions such as angioectasias, and very occasionally we'll find a new diagnosis of inflammatory bowel disease. And normally these patients are fairly symptomatic and they simply haven't sought any medical attention for these symptoms earlier. I think it's also worth noting that a significant proportion of patients will have a completely normal colonoscopy with no significant findings because the test is so sensitive for such small traces of blood. And I think for patients undergoing their colonoscopy who've had a well-prepared colon, so a good technical procedure with a suitably credentialed colonoscopist, they can be very, very reassured by that normal finding rather than sort of being stressed out or worried that something's been missed. So we see a lot of patients will have a normal colonoscopy.
When we're looking at a normal endoscopy, so normal macroscopic findings, do you still take histology samples?
As a general rule, the endoscopic diagnosis, especially around cancer and polyps, is based on visual findings. So if you don't see a lesion, you're not going to sort of biopsy looking for it, that they're visible findings. And this has been a sort of an increasing paradigm shift in colonoscopy as we have higher resolution endoscopes and there's more data coming out about features to characterize lesions. And a lot of this has come from our colleagues in Japan, where they're scarily accurate in predicting histology of polyps and cancers just based on the endoscopic appearances. So usually if the colon appears normal, we wouldn't take any histological samples other than probably in the setting of patients with chronic diarrhea where they can have microscopic colitis, and as the name implies, there may not be any major visible sort of endoscopic finding. The other thing I'd like to the other point I'd like to make about histology, and hopefully, Travis, you agree about this, is that when we obtain biopsies of colonoscopy, and especially from a large lesion that looks like a cancer, there's always going to be a limitation based on the material us as endoscopists provide to you, the pathologist, and there's always the potential for a sampling error. And what this means is that sometimes a lesion that I look at and go, this is clearly a cancer, I take a biopsy, I send it to you, and you come back to me and say, well, look, you've sampled a tubular villus adenoma with high-grade dysplasia, but I can't see any cancer. That doesn't mean this isn't a cancer, or that as a pathologist you haven't sort of seen that area, but it's a reflection of heterogeneity within these lesions. And so certainly now it would be generally accepted that if a lesion had typical endoscopic features of a malignancy and it was felt this was not suitable for endoscopic management, then these patients now would go ahead and be treated as a cancer, even without necessarily having that histological confirmation and without the sort of inconvenience and delay of having a repeat colonoscopy to have repeat biopsies.
When you do encounter polyps, what do you normally do? How is your management with that?
Like many fields in medicine and surgery, there's this progressive shift to less and less invasive intervention. And there's now sort of excellent short and long-term data that benign colorectal polyps, regardless of their size, should be considered for endoscopic rather than surgical management. And so whether it's a 5 millimeter polyp or a 5 centimeter polyp, these are all lesions that should be able to be managed endoscopically. So what we do when we encounter a polyp is firstly to closely endoscopically assess this polyp and try and predict the histology on the basis of it. And using sort of high definition, high resolution endoscopes and various sort of digital and optical enhancement features, you can actually get really good assessment of the surface and vascular patterns. And this, with high accuracy, allows us to distinguish between benign polyps and cancer, as well as sort of distinguishing adenomas and serrated polyps. Once we've had a good look at the lesion, then the endoscopist needs to decide whether this can be resected during that same colonoscopy procedure, and probably in excess of 95% of polyps can be dealt with at that initial colonoscopy. And so we'll resect it, and then once it's removed, then the polyp specimen is retrieved and sent to histology to, I guess, not only confirm that the polyp is benign, but also to give us more detailed histological information in terms of the degrees of dysplasia, whether it's a serrated lesion versus a conventional adenoma, because these things make a big difference in planning future surveillance. With larger polyps, these can be more difficult to resect endoscopically, and they often require subspecialty expertise to be resected completely and safely in a single procedure. And so these sort of polyps, when they're encountered, will often not be resected at the index colonoscopy, and that these patients are then referred to an appropriately trained interventional endoscopist who has expertise in managing these lesions. For typically benign appearing polyps, even when they're very large, these lesions typically now won't be biopsied, as the biopsies can cause fibrosis and scarring under the polyps and make subsequent resection more difficult and risky. So they're just very well photo documented, good pictures are taken. And so when patients are referred to me with very large lesions, they generally now will come with good photos. And on that basis, you can usually tell that the lesion is benign.
The challenge for doctors and for patients in this area is that the screening patients are the general practitioners. They'll be referred to gastroenterologists for investigations, but then they potentially fit into this sort of grey zone where if it's not cancer, because we certainly know what to do with cancer patients, they'll go to a multidisciplinary meeting. But the report then, let's say it's a sort of suspicious polyp that is of concerning, the report will go back to the GP. Will the GP know that that patient will probably need further management, or where does the sort of information reside as to the reporting of possibly a patient who fits into this grey zone of what do I do now with them?
Look, you're right. It's a really kind of murky area because there's so many pathways for patients into their colonoscopy. At least in New South Wales, there's been a bigger and bigger push for direct access screening colonoscopy services through the public hospitals. So patients will go through their GP, often through a nurse-led clinic, have their colonoscopy and then be sent back to their GP for results. A lot of private endoscopy services will also offer a similar sort of direct access colonoscopy service as well, especially for patients in otherwise generally good health. They may also get seen in public hospital clinics beforehand. They may get seen in private consulting rooms. And then every individual practitioner and service also has a slightly different way of doing this in terms of how they plan their follow-up. Direct access services generally tend to rely on patients following up with their GP to go through the results of the procedure and the histology. And any well set up direct access service should be providing further screening and surveillance recommendations, both in terms of the time frame if the patients need further colonoscopy as well as the best modality. And the colonoscopy clinical care standards also do sort of set this down as one of the criteria for sort of good quality colonoscopies, that the reporting needs to have guidance on follow-up. Generally, patients with high-risk findings or cancer will be followed up with that endoscopist to ensure that there is appropriate follow-up, staging and surgical review if it's indicated, and that's all that's been arranged. And I think for GPs, if you get a report back and it's unclear on the follow-up and surveillance, then the best thing is to just get in touch with the endoscopist who's done the procedure and say, hey, look, I've got this report, wasn't sure, what the plan was here. What do you suggest? And I think me and my colleagues would always be happy to provide some clarity around the follow-up plans then.
So if someone has a negative colonoscopy, what does that mean for the patient and future screening?
So colonoscopy is a really accurate test for colorectal cancer, and by far and away the best sort of test for colorectal cancer compared to imaging or any other modality. And a negative colonoscopy carries a very high negative predictive value as long as it's been a good quality colonoscopy. So the bowel prep's worked well, the colonoscopy has been carried out by an endoscopist who's been appropriately credentialed and maintains high-quality indicators such as their adenoma detection rate. And so for an average risk individual, in the 10 years after a normal colonoscopy, we'd expect the risk of colorectal cancer would be very low. But I guess like everything in life, there's no such thing as perfection. And so for patients, and I guess for GPs as well, that a patient who develops new or concerning symptoms or clinical features, regardless of the time since their last colonoscopy, should be reassessed with a low threshold for re-referral. In terms of future screening, so if you have no colorectal cancer identified and no polyps and your patient's asymptomatic and well, I guess determinant is very much based on whether they have other risk factors, so whether there's a family history, an underlying polyposis syndrome, and that sort of thing. If they have none of those features in a normal colonoscopy, then probably resuming bowel cancer screening with fecal occult blood tests in 5 to 6 years' time would be a reasonable approach. If the patients have had polyps but no cancer, then the size, number and type of polyp will determine the surveillance intervals, and there's pretty well-defined guidelines now for when that should happen. And certainly in Australia, we haven't gone down the pathway of places like the USA where they look at just population-based screening colonoscopy every 10 years. We don't have the capacity and the resources to be able to do that. I guess the other thing that's sometimes raised is about when to stop screening or surveillance. And I think we're very good at kind of going, okay, age 50, the bowel cancer screening starting, or you've got the family history, should start undergoing your colonoscopy. But we also need to be mindful that, especially when we're doing it as a screening test, that this is not something that should just continue forever. And the first factor is the patient's general state of health. So if they've got other severe or advanced comorbidities that mean they wouldn't be appropriate for any further therapy if a colorectal cancer was identified, then asymptomatic screening really isn't going to give that patient any benefit, and so it's probably not appropriate. The National Bowel Cancer Screening Program will routinely send out screening kits to patients up until the age of 74, and given the age of 74, if you were to have a positive test, a normal colonoscopy, then the risk of developing colorectal cancer in the next 10 years would be very low. And I guess given then mid-80s is around the average life expectancy for an adult in Australia anyway, stopping any form of screening after that is probably appropriate. For patients undergoing a polyp surveillance or monitoring due to high-risk conditions such as a polyposis syndrome or a major family history, then it's a bit more of a nuanced and personalised approach that you'd need to take.
My goodness, that's a very comprehensive answer. Thank you, Milan. Although you did say at one point there's no such thing as perfection, and I'll be quoting that whenever I have to apologise to my wife or daughters for anything, so thank you. Just in closing this interview, is there any final thought or advice you have for doctors and patients?
I guess firstly for patients, it's hard to overemphasise the importance of the National Bowel Cancer Screening Program. And I think whilst there's this kind of ick factor associated with collecting the stool test, there really are tremendous benefits. And so if you have a colorectal cancer and it's detected early and before it causes symptoms, there's a much higher likelihood it will be at an early stage and then be much more likely that it can be cured. Probably even more importantly than that in the long term is finding and removing then significant precancerous polyps will significantly reduce the future risk of colorectal cancer and colorectal cancer-related mortality. For GPs, I really like to encourage your patients to undergo bowel cancer screening. because I think the biggest barrier to colorectal cancer screening is the patient participation rate. And as a GP, patients will often turn to you as their sort of most trusted source of health information, and some gentle encouragement will often go a long way to get the patients to engage in screening. It's also worth sort of knowing your local pathways to help expedite patients for colonoscopy with positive FOBTs, and whether that's through your sort of local private endoscopist, through the public health networks, or your hospital's sort of gastroenterology or endoscopy service.
Dr Tristan Rutland is an anatomical pathologist and lecturer at Liverpool Hospital and based at Western Sydney University. He has a subspeciality in research interest in GI pathology and asbestos-related diseases. In 2020, he was the recipient of the Conrad Muller RCPA Outstanding Teaching Award. In 2022, he received the Resident Advocate Award from the College of American Pathologists. Tristan is a regular guest on This Medical Life, and we welcome him back today. Welcome, Tristan.
Thank you again for having me back. I always love coming on this podcast.
Well, when you've won a teaching award, that means you're a guest for life.
That's very, very, very kind. But no, it's an absolute joy. I really enjoy these, and I learn a lot from your podcast as well. So great to be a part of it.
Tristan, I want to start right at the basics and ask you, what is a polyp, and is a polyp and adenoma the same thing?
That's a really good question. I suppose the thing is, what do we define as a polyp, and what the general public think of as a polyp, and what do we think as doctors, and medical students and such alike, and what the terminology is. So very simply, a polyp is any sort of like excretion bump, if you may, in a mucosal surface. And when I say mucosal surface, I say basically from the esophagus right down to our anus as well, is all lined by mucosal surface. And it usually arises from what we usually say glandular epithelium, so the stuff that lines our intestines and stomach and so on and so forth. So we get polyps in our stomach, we get polyps in our intestines, we even get polyps in our gallbladders as well. Interesting enough, just on a side note, when we get it on surfaces that are lined by like skin squamous epithelium, we tend to call them papillomas. It's just a slight little terminology thing as well, though. Essentially, it just means polyp just means a bump in a mucosal surface. So it is a bump, and quite often we'll say, oh, there's a polyp. And the ultimate decision of if it's an adenoma, which I'll define in 2 seconds, is really something that as a pathologist is what one of our jobs really is as well. So something can look like a bump in a mucosal surface, and you can take it out and give it to the pathologist, and we can decide if it's something called an adenoma. And just as a refresher, when we talk about different types of what we call neoplasia, so basically cells that are starting to replicate by themselves as well, we put them into benign and malignant categories. So when we talk about adenomas, adenoma usually is a benign proliferation of cells that arises from an epithelial surface, usually a glandular surface, so like the intestine. So when we get cells that start to just ignore the body's function and grow and grow and grow and grow, but they're benign, we call them an adenoma. When they become malignant, we call them an adenocarcinoma, just as a definition. So an adenoma, when we talk about an adenoma, we're suggesting that it's a benign, which doesn't mean that it's not precancerous, but it's a benign, it hasn't invaded as such, proliferation of those cells. And that's a very specific definition. So polyps can be adenomas, but polyps, which is one of the things we're going to be talking about a little bit later on, because that actually has particular reference to colorectal cancers. But on a different note, polyps can also be other things. We can look at something and say, that looks like a polyp, and take it out. And in actual fact, it's not something that's on the surface. It's actually something underneath in what we call the submucosa, beneath the stuff that supports the surface of the epithelial surface, the surface of it as well. Or it could be actually sometimes if we get inflammation, the body can actually get what we call inflammatory type polyps. It gets irritated and the body tries to react by protecting itself and growing more of it. And they're actually benign there as well. So polyps is sort of a bit of a grab bag term for a whole bunch of different bumps that we can get in. We're talking in reference now to the colon, why adenomas are a particular type of thing. They're an actual type of proliferation of cells. Usually they've got a mutation and they're growing, and as a result, they're growing because they've got nowhere else to go and they grow up and they form a bump. So that's a very long answer for a very short question.
Do all adenomas have dysplasia?
So that's another really good question. So when we talk about the different types, that's probably going to become more important because when we talk about adenomas, we're just now moving to the adenoma sort of like group as well. And we use the term dysplasia. And it's a really interesting sort of question because when we talk about dysplasia, it's something that as pathologists we see under the microscope. It means the cells look abnormal. Once again, they're looking pre-malignant. They've got mutations as well. And when we talk about the most common types of polyps, we'll talk about the adenomatous polyps, the ones that include the tubular adenomas, which are really common. They all have dysplasia as well. And when we talk about the groups a little bit later on, we can expand upon that. There's another group of polyps which also can be precancerous called sessile serrated adenomas, which basically sessile means flat, serrated means they have a little sawtooth appearance under the microscope. Adenomas. We don't traditionally say they have most of them don't have dysplasia, even though, funnily enough, they have little mutations in them. But if they start to get the sort of what we call dysplasia, i.e. they start to look like a tubular adenoma, then we get really worried about them because it actually means that those are actually more aggressive type things as well. So once again, a long answer to a short question is that not all adenomas will have dysplasia as well. But in certain situations, when we actually start to get dysplasia in certain types of adenomas, it can be really quite bad. And conversely, some adenomas actually are defined by the fact if they have dysplasia or not. That actually makes that diagnosis as well. And also, it's important when we talk about the degrees of dysplasia later on. That's another important thing to come back to.
Now, you've touched on it in just some of your answer already, but there's a few different types. Why are there so many different types of colonic polyps in the World Health Organization tumour guide?
Yeah, so once again, I think it's just, that's once again, good question. And I think the thing is that why are the different types? Well, the short answer is we like to splint or lump things into different groups because it really to guide what we do with these things. Well, they're prognostic, they're clinical guidelines. What do we do if we've got these types of polyps? What's the significance of them? So, one benign sort of polyp might mean, that's maybe a hyperplastic polyp might really not mean too much. But if you have a particular subtype of polyp, you need really quite aggressive follow-up as well. So one of the reasons we split them up is really to guide what we do with them. What do we do? It's a management decision as well, and also a bit of a prognostic decision. And it's also, when we talk about it a little bit later on, different types of polyps and having lots of them may actually suggest the patient may have some sort of underlying genetic syndrome, especially if they get lots of a particular type of polyp. It might guide you to think, they have this particular type of syndrome, or if they have a particular type of that type of polyp, they might have that particular type of syndrome as well. In regards to the different types of polyps we have, broadly speaking, when we talk about the ones that are relevant to colorectal cancer, we can divide them up into a couple of main groups. The most common one, I would say, and it's the adenomatous group, which, once again, it sounds a little bit misleading. It's the conventional adenomatous group. Let's use that word. It's probably a better term, I think, which is made up of the most common type ones, which are called tubular adenomas. They're the ones that do actually have dysplasia, they're defined by having a bit of dysplasia. They're the ones that sort of look classically through medical school, they actually look like a classical polyp. They look a little bit like a mushroom sometimes as well, with a stalk. They can look like that. And that goes all the way through, and that group also includes some of the more less common but more aggressive types, which we call tubular villus adenomas, where they start to get more frond-like, and then we have villus adenomas, which actually can sometimes carpet, and those ones tend to be more aggressive. So that's that conventional adenomatous group of polyps as well. And the tubular adenomas are probably the most common one you're going to come across, as well, or certainly what we talk about in this group as well. Then we have this other group called serrated polyps as well. We have, there's a type of polyp called a hyperplastic polyp, which they probably think most of them are what we say reactive, i.e. they don't really have any mutations. But we're now beginning to find that some of those particular types of hyperplastic polyps might be precursors to other types of polyps. So nothing's ever straightforward in medicine, of course. No. You just think, they're just reactive, whatever. But now we know that some of those ones might actually have little actual mutations that might lead on to different types of polyps. But in that, so that's hyperplastic polyps, and that's part of that serrated polyp group. But the big part of that is what we call sessile serrated adenomas or lesions or polyps. There's always a bit of a debate amongst pathologists. I'm sure you agree, Travis, that what term do we use for that as well? So some people use lesions because they're flat, because sessile means flat. Some people, I actually think adenoma is not a bad term because they are a type of adenoma. They're a benign proliferation of epithelial cells. And those ones, and when we say serrated, once again, it's what they look like under the microscope as well. So we have them in there. So those ones sort of don't have that dysplasia under the they don't have dysplasia as well. But they can get dysplasia, and when they get dysplasia, they become much more aggressive. It actually is a hallmark that they've actually got some pretty nasty mutations, and they can progress rapidly into cancer as well. And they can have funny types of dysplasia, by the way. And then I suppose the last group is there's something called a traditional serrated adenoma, and they can, they're sort of a funny group of ones. They're pretty rare, but they can sort of once again turn into cancer. They can actually get some dysplasia in them as well, which obviously means they're much more advanced. And the last thing I should touch on is that just inflammatory bowel disease. I should just mention that people that have long-term inflammation anywhere in the body can get cancer, but in the colon, if you have long-term inflammation, you can get so that term dysplasia, abnormal growth of cells. And people with inflammatory bowel disease can get polyps, like those ones that we talked about. They can actually get what we call pseudopolyps, which are just islands of regenerative epithelium, which looks like polyps, but that they get sampled and that's what they are. But they can actually get they can get other types of polyps. But more importantly, sometimes they can get what we call dysplasia, but it can be flat and it can be almost, I think in an episode previously we discussed this, where they can actually get dysplasia, i.e. they can get mutations in their cells due to all that inflammation. And that can be a precursor to cancer. And the problem with those things is they can be hidden and it can be hard to be seen as well. And I know that's not strictly a polyp, because in actual fact, one of the definitions is it doesn't look like a polyp, but it's important to include that in this discussion about polyps and adenomas and precursors to colorectal cancer, because it's an important one that the gastroenterologists will do sampling biopsies to look for this. They'll sample polyps, but they'll also sample to look for this invisible dysplasia, which, like I said, in most people that don't have inflammatory bowel disease will be polypoid, but when you've got inflammatory bowel disease, it can be flat and difficult to find as well.
Now, you've segregated those into groups well for doctors and medical students. If we've got a report that you've written, what should they be on the lookout for a polyp that comes their way?
When we talk about those different types of polyps, I think first of all, dysplasia. And once again, a lot of this will be done by the person that has done the colonoscopy as well, but I think it's really important for GPs and medical students to understand, they need to know this, they need to manage it and explain it to the patients, and also need to follow up as well. Dysplasia is an important thing. It's an important concept. So when we talk about tubular adenomas, we talk about, and that conventional adenomatous group, they're defined by having dysplasia. And it's almost, most of the time it's low-grade dysplasia, which is like, if you get a tubular adenoma with low-grade dysplasia, that is par for the course. That's just what we expect. But we go looking for, see if there's a cancerous component. But we also look for if the dysplasia, I said to use the word low, Then the next step is high-grade dysplasia. And if we have high-grade dysplasia in those conventional polyps, that's a higher risk. Now, once again, I know that the person that's done the colonoscopy will usually follow that up and depending on the degree of it and so on and so forth will depend on how often they follow up and what they do. But having that high-grade dysplasia is a high risk, and it means that that polyp has now got more mutations and it's much closer to becoming a cancer as well in that conventional polyp sense as well. So I think that understand if you see that high-grade dysplasia in a tubular adenoma, you need to make sure that patient's being followed up and managed as well. Cess-ulcerated adenoma lesions, that serrated group, what do you need to know? If you have the word dysplasia with that second group, that's once again a very aggressive type thing to be aware of. So that is a very similar sort of thing. If you've got that, that's an aggressive type of tumour, so the management and follow-up is a lot quicker, and people keep an eye on it, might do some things, especially they might even resect the whole polyp if it's large as well, if it's got that in it as well. What other things? Well, I think that especially GPs are in a really good position to sort of put a lot of things together. If you've got a patient that's got a lot of funny types of polyps, and they might have had other things that, as specialists, we sometimes don't get the full picture. So they might have had other tumours removed. You might have removed some skin cancers or skin tumours, or they might have a family history, or so on and so forth. Some of these things might not be apparent. If the patient has lots and lots of polyps, that might trigger something about some sort of genetic syndrome as well. That's another important thing I think to think about. So making sure that the patient has if they've got lots of different polyps, and not just the conventional adenoma polyps, but we're talking about the serrated polyps, and some of even things like Peutz-Jeghers syndrome can have funny sort of types of polyps in the colon. The patient has been investigated for something like that as well. I think that's an important thing. And I suppose the last thing is that when we talk about polyps, it takes about, for that conventional pathway, it takes about 10 to 15 years for some of those polyps to turn into cancers. Not all of them do, but some of them do. And if you've got a family history of colorectal cancer, you want to make sure that patient, if they've got it, they're getting screened about 10 years before their family member that got cancer to look for those polyps, because we, like I said, know that those polyps over a period of time can turn into it. So once again, putting all that stuff together is really, really important as well.
Can I just interject? Because this is my hobby horse. You've just pointed out, Tristan, how the GP, boots on the ground, can bring things together from that local knowledge. And I remember Napoleon floundered when he tried to go to Russia. He wasn't listening to the troops on the ground. It was all up in the top. And so yet again, here in medicine, it is a team that's at the coalface for the best outcome.
Absolutely. And I think GPs are a really good place to get that full picture. And they'll have all the information, and they'll have information available to us. Sometimes we'll phone a GP, if I've got a difficult case in front of me, and I can get a wealth of knowledge that I might not have. And I can speak to the treating specialists as well, but they might not have access to all that. So, yeah, absolutely, I agree with you as well. It's just that having someone to put all that stuff together is so, so important, especially in situations like this, yeah.
When touching on family history of cancer and polyps, is it important to know when and how they sort of develop?
I think it really is. And I think I sort of talked about it does take about that 10 to 15 years and realizing that because these polyps take about 10 to 15 years, I'm saying not all the polyps turn into cancer but the chances of adenoma from turning from one of those conventional adenomas in particular, transitioning to adenocarcinoma is about 10 to 15 years. We need to know that patients get adequate follow-up. So if you get a polyp, if you have if a lot of these polyps So just to give a bit of context, if you have an FOBT, about a fourth of people will have a colonic polyp, one of these types of adenomatous polyp or serrated adenoma type polyp. And they'll be follow-up about 5 years, I think, just because we want to make sure that, we're not missing one of those polyps that will then turn into a cancer over that, given that time frame. But on the converse, you mentioned the family history, and I alluded to it before. If you've got a strong family history of colorectal cancer, you want to then go back. You want to make sure that you're screening the patients 10 years before that family member, the family member had cancer, got their cancer, because we're looking for those polyps that are starting to develop, 10 to 15 years before that, and sampling. And it's also, if you then do a scope 10 years before, say, for example, your mother had colorectal cancer when she was 40 and you do it at 30 and you find a couple of colonic polyps, you're doing that patient a really good service by, A, identifying the fact they've got risks, and B, taking out those polyps so they don't go any further as well. And I think that's the really important thing. But then again, I think I alluded to it, then we have some of the high-risk polyps, and then if you have one of those things, the follow-up time's a lot quicker, because we know that those things progress because they're a bit more along the line towards turning into cancer.
Tristan, what would you define as a malignant polyp? And do patients need an operation? How do we work out who does?
That's one of the questions that we have at our multidisciplinary team meeting. That is, pathologists have a very important role in all of it, but it's one of the ones that we really buckle down on and have to make sure that we get right. A malignant polyp is one of those polyps we talked about. Generally, it's that conventional adenoma, but it can be one of those other sessile serrated adenoma type polyps that has progressed beyond having. So it's no longer what we call an adenoma. It's a benign proliferation. It's now become a carcinoma. So it's an adenocarcinoma. It's the cells there have just got that extra little bit of mutations where they've got the ability to invade into the tissue and start to invade as well. So if we find a polyp and we look under the microscope and we find that there's a polyp, there's an adenoma, and then there's invasive cancer in it, we call that a malignant polyp as well. Some of these things can be expected, and I think you may be you'll be talking to a gastroenterologist as well, Milan, who is very good at picking up these things, because sometimes the gastroenterologist or surgeons may not suspect it, take it out, and they get a bit of a rude shock when they get the report back, or we phone them and say, this polyp's got a cancer in it. Or sometimes they may suspect the polyp, they look at the polyp and they usually inject some dye, and if it doesn't lift up, they'll go, ooh, this polyp looks a little bit more worrying. So it may be expected or unexpected. So yeah, a malignant polyp is a polyp that has a cancer in it, and it's important for us, to pick it up, because it may be an unexpected thing, and therefore it may not be something that was necessarily rushed through in routine practice, and it might be a week or two or longer until they get that report as well. Like I said, or it might be suspected. Then the next decision is, what do we do? Because a patient has got an early cancer, that has got an early cancer. What do we do? And it's really important. There's a bunch of risk factors that we look at. So there's it's always good to break it up into disease factors, i.e., what has the cancer got about it that is bad? And what about the patient? Because some patients may not be suitable to have an operation. Because the decision is, do we leave it alone? What's the risk if we leave it alone? Or do we need to do an operation to, A, reduce the risk of the patient getting progressive disease and getting metastasis and dying from eventual disease, and also checking to make sure and when we do the operation, of course, we can look at the lymph nodes and the pathologist can do the full assessment, as opposed to having the polyp where we can only just look at the polyp. So what are the things about the disease or the polyp that may suggest that the patient, or pushes us towards the patient having an operation? First of all, is how close is the cancer to where the margin is, i.e., where they've actually scooped the polyp out? How far is the cancer? How much clearance have we got? Generally about less than 1 millimeter is considered involved. That's all high risk, so we get a bit worried if it's less than 1 millimeter as well. Other things are, has the cancer got into blood vessels or into the lymphatics or blood vessels, which means it can spread. So that's a higher risk. These increase the risk of you getting, metastasis or lymph node metastasis in particular as well. So these are risk factors. Another risk factor is things like what we call something called tumor budding, which sounds like a nice little thing, but it's quite horrible. It's where the tumor, when it starts to spread, it actually sends out little sort of almost like scout malignant cells into the tissue in the advancing front. So 1 to 4 little cells, and then grows from there. Now, we know that if you have lots of tumor budding, i.e. there's all these little single malignant cells that are sort of at the advancing in front of like scouts in front of the cancer, that's bad. So we try and put all that together. And we put that together in an MDT setting, and we talk about it with the surgeons and the oncologists and so on and so forth. And then we look at the patient. Is a patient, and sometimes decisions can be made on, is it going to be worthwhile for the patient to have this operation if they might have one of those factors may suggest they may have about 20% chance of having a metastasis in their lymph node. But if they're really, really unwell and won't survive an operation, they've got an 80% chance of dying, just making these numbers up. It's not really worth the patient having an operation. So there's that decision-making thing. And sometimes patients might not want to have an operation. And there are other things sometimes you can do, just do a little local resection to try and actually, and some of the gastroenterologists, like I said, can actually do a little EMR, remove the area where the polyp to see if there's anything there. That might be a compromise in some situations as well. But they are a tricky area, I think. And there's a depth of invasion, how far. There's some other little factors which I won't go into for brevity's sake, but in essential, we look at how bad is the polyp, what are the risk factors associated with it, and then look at the patient as well, and then make the decision. We'll make the decision or have a consensus, and then give it to the patient. And the patient can ultimately decide what they want to do, and they can make an informed decision.
What are some of the syndromes associated with colonic polyps?
Great question. So it's interesting. One of the things is, I suppose, and I know that you guys are both great fans of history, and I don't know if you might have discussed this at the beginning of your episode, but I remember when I did a talk about this, one of the first things that was interesting is that, particularly in things like familiar FAP, so familial adenoma polyposis, the syndrome was described a long time before the association with cancer. So interesting enough, people knew a lot about these polyps as well, and it wasn't they knew ages ago, and it wasn't until like 100 or 150 years ago they actually sort of beginning to realize, these polyps had an association involving cancer, and we realized that life expectancy and so on and so forth as well. So something like FAP, about almost 100% of people get colorectal cancer, by the age of 40 with it as well. So I suppose that's just to put it in a little bit of a historical context, and also things like Lynch syndrome as well. So first of all, I suppose one of the things is people that have a family history of colorectal cancer quite often don't have a definable syndrome. Just, they might have that sort of like group of people that, they've got a family history of cholera, and they don't have a definable syndrome as we learn about FAP or Lynch syndrome. That said, when we talk about those particular things, it's interesting, and going back to my history talk, is that one of the ways, and we'll talk about the pathways a little bit later on, is that the pathways were sort of actually described with the pathways, so the different ways that you can develop cancers, were sort of actually described in conjunction with the polyps. So they sort of described the polyps, and then they described the pathway through the polyp in FAP, and realized that actually was the pathway to what we call the conventional chromosomal stability pathway of developing colorectal cancer, the ones associated with lots of tubular adenomas as well. And we realized that FAP was associated with that because and interesting enough, the gene that's associated with that one is called the APC gene, which is called the adenomatous polyposis coli, I think, gene from memory as well. And then the other syndrome, which is commonly associated with polyps, is something like Lynch syndrome as well, which is, we'll talk about mismatch repair deficiency. So microsatellite unstable cancers can arise from this, which is where we get a mutation in one of the DNA repair enzymes that looks after microsatellites. Expand upon that as well. There are also other syndromes that are rarer, but they do exist, and things like Cowden syndrome and so on and so forth. There's Mutori syndrome, which has got type A and type B, which has got, one of them is associated with Lynch syndrome, and one of them is associated with something called MYM MUYTH polyposis, which is probably type 2. So there's a whole bunch of, I'm not trying to confuse you, I'm just trying to say there's a lot of them out there as well. But I think to round it all up is that if you have lots of polyps, and there's definitions in the WHO that says if you have this many polyps and they're greater than this size, yada, yada, you should consider this as well. But as a general feeling, if a patient has lots of polyps, especially if they're youngish, you probably should think about some sort of polyposis syndrome. And the different types of polyps can suggest different pathways. Because remember, we're talking about polyps as in adenomas. They are this pre-malignant lesion that sort of is getting cells, getting more and more mutations and eventually turning into cancer. And different syndromes, because they have different, they usually evolve a tumor suppressor gene or a DNA repair enzyme, are usually typified by the loss of these. And that's one of the first things that goes in the syndromic type cancers is you lose a tumor suppressor gene because you've got one less of them. And different types of syndromes can give rise to different types of polyps, and that could be a bit of a suggestion of what the different types of polyps are. But yeah, it can be quite a complex question, and a good clinical geneticist can probably expand upon that as well. But I think as a general rule, lots of polyps or just unusual lots of polyps probably just trigger that, has this patient got a polyposis syndrome, even if they're hyperplastic polyps. Lots of hyperplastic polyps by themselves could suggest it. And sometimes things that can look like hyperplastic polyps can even be suggestive of a funny sort of syndrome as well.
Do you do any molecular markers on polyps?
Yeah, it's an interesting discussion. No, not really, no. There was a bit of a push to do, and if we talk about the molecular pathways a little bit later on, there was, especially for people that have things like Lynch syndrome, there was a bit of a, should we be doing it? It was interesting, there was a talk that I watched recently that actually discussed about should we be doing these markers to pick up people that have particular genetic diseases, and the pickup rate is so small it's not worth doing it at all. It's just so small, and the benefit is actually is not there. So as a general rule, we don't tend to do molecular markers on non-invasive polyps with dysplasia, so no.
Tristan, this has been a fascinating conversation. I'm picturing Tim Burton crafting a deep subtropical rainforest with all these bizarre growths and whatnot on the floor. It's just it's a fascinating insight that you've given me that will haunt my dreams for many, many months. Just to tie a knot in it, are there any final thoughts or some final advice you'd like to give GPs in relation to this?
I think the main thing about when we're just talking about polyps, the person that has done the colonoscopy should have it in hand, but making sure that, if they've got the full patient's history there and they need to make sure that the patient is getting the adequate follow-up, is making sure that if they do have lots and lots of polyps, it doesn't trigger them for further investigations, especially if they've seen other specialists and they have polyps polyps at other sites or other types of, or had a previous history of other tumours. It might be a hallmark of something else going on. So maybe if GPs do get a report back, lots of polyps, and they've had some other unusual tumour, it might be worthwhile thinking a little bit as well. And also just we're realising there's a big spectrum of what we call polyps out there. Like I said, things that aren't involved in colorectal cancer that might be some, that are just to do with inflammation or some sort of soft tissue tumour. But the ones that are involved with cancer, there are of different variety, and the aggressive ones need to be just treated carefully, and patients need to make sure they get followed up because their risk of getting cancer is higher. So just knowing that we put subtypes there because we try and tell what the prognosis is and the follow-up, so making sure the patient has that. So making sure they're getting the polyps they've got are being adequately followed up as well. Like I said, the people that do and colonoscopy is very good at doing that, but it's always good. But also making sure they're not missing that the patient hasn't got something else going on, and they can put all those sort of things together as well.
Dr. Tristan Rutland, thanks for being part of this medical life.
Thank you again.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis.
This has been a PathNotes Proprietary Limited production.